Hi guys, today we're going to talk about contraceptives. There are all different forms of contraceptives that patients can use to prevent pregnancy. There are hormonal and non-hormonal means of contraception. The most common methods that patients typically use include the pill, female sterilization, and the male condom. Other types include the patch. So instead of taking hormones via a pill, there's a patch that can be applied that delivers hormones transdermally through the skin. An implant. There are hormonal implants that can be implanted either intravaginally or under the skin, and they slowly release hormones. And then and other implants as well, actually, not just hormonal. And then other barrier methods, for example, the diaphragm, which is a female-based barrier method as opposed to the condom, which is male-based. Failure rates with contraception vary from 0.25% all the way to 28%, which 28%, that's 1 in 4 failures resulting in pregnancy. So that's a pretty huge failure rate. If you look over here, this is just showing us the percentage of each type of contraception that is used. So again, you can see the pill, combined estrogen and progestin hormone pills are most common, with 16% of people using this as their means of contraception. And then female sterilization, male condom, intrauterine device, vasectomy or male sterilization, the withdrawal method, which is just withdrawal of the penis before ejaculation occurs, injectable hormones, other, and then a vaginal ring. Over here you can see the failure rate or relative failure rate, with sterilization being very low, male sterilization being lower than female sterilization. Even lower than that is the hormonal implants. Hormonal implants have very, very low failure rates. Intrauterine devices, there's the hormonal intrauterine device, and then there's also the copper intrauterine device, which also have very, very low rates of failure. So if you had a patient who was on medication, for example, that was teratogenic, and they could not get pregnant, period. Like, that is not an option. These are all very, very successful rates of or forms of contraception. Now, other agents like injectable or combination oral, contraceptive patch, these are all vaginal ring, these are all relatively effective. Keep in mind, these failure rates that you see here are like overall failure rates. Sometimes patients are not completely effective in the way that they use the contraceptive method. So if a patient doesn't, say, take the medication every day, period, and if they maybe take medications with the pill that interacts with it, or they forget a couple days, or things like that happen, and that can affect this, what we see failure rate. So if the drug is used appropriately, or like down here with condoms, if you look at the failure rate with condoms, using a condom appropriately and correctly, and a condom that is new, that hasn't been, in someone's wallet for the last 5 years, the success rate is probably higher than what you see here if everything is used appropriately. So if people are careful, that helps. Hormonal contraceptives give a combination of estrogen and progestin. And the estrogen and progestin work in kind of different ways. Just to review reproductive hormones really quick, remember this all starts up at the hypothalamus. The hypothalamus releases pulses of GnRH, gonadotropin releasing hormone. GnRH goes down to the anterior pituitary gland and causes the release of FSH, follicle stimulating hormone, and LH, luteinizing hormone. And both of these are important in different kind of phases or different parts of the uterine and ovarian cycle. Estrogen inhibits the release of FSH via negative feedback. These work via negative feedback. Estrogen inhibits the release of FSH, or follicle stimulating hormone, which FSH stimulates the development of the follicle. Progestin works by inhibiting LH release from the anterior pituitary gland. LH is important for stimulating ovulation, so inhibiting LH inhibits ovulation. Which ovulation is obviously the release of the egg from the ovary. If you don't release the egg from the ovary, then there's nothing to fertilize and pregnancy does not occur. Progestin also thickens cervical mucus. Thickening the cervical mucus makes it harder for sperm, or inhibits sperm motility. So it's less likely that sperm are going to be able to actually go up through the cervix into the uterus, where the egg would be fertilized in the uterine tube. Finally, withdrawal of the hormones stimulates uterine bleeding. This occurs during the placebo week. Of contraceptive pills. When patients receive 28 days of contraceptive pills, or one full cycle of contraceptive pills, there are 3 weeks or 21 pills of actual hormones. And then there's 7 pills. That last week of pills is just placebo pills. That stimulates, or that's when there's a complete withdrawal of hormones. When those hormone levels drop, that causes uterine bleeding, right? The endometrium of the uterus is shed, and as that exits the vagina, that's the period or menstruation that occurs. Adverse drug effects of estrogen include breast fullness, fluid retention, headache, nausea, increased blood pressure, and interference with lactation in women who are breastfeeding. Also, we can see the more serious adverse drug effects of thromboembolism, thrombophlebitis, MI, and stroke. Now, this is more common in patients over 35 years old who smoke. We see a much greater chance of clot formation and stroke in patients over 35 who smoke. So you should avoid estrogen-containing agents in this population of patients. So if you have a patient who's over 35 who smokes, do not give them an estrogen-containing hormonal contraceptive. Progestin only agents are recommended in older women who are smokers. So there are hormonal agents that are not combination agents. There are progestin only. So progestin only agents are recommended in older women who smoke, because it's the estrogen that has the stroke risk. Adverse drug effects of progestin include depression, changes in libido. Hirsutism is like hair growth in areas where there normally wouldn't be in a woman, and acne. There's also a cancer risk. There is an increased risk of cervical cancer that is possible. This increased cervical cancer risk is not because the drugs are actually causing it. So, and this is a common misconception. These hormonal agents aren't causing cervical cancer, but there is an increased cervical cancer risk in patients who are on hormonal contraceptives. And the reason for this is that patients who are on hormonal contraceptives are less likely to use a condom. So patients less likely to use a condom, which increases the risk of HPV. When somebody is on hormonal contraceptives and they're not worried about getting pregnant anymore, they're much less likely to use a barrier method or a condom. So the condom is necessary to prevent STDs, not just pregnancy. So if somebody is, sexually active and not using condoms, they're a lot more likely to get HPV, human papillomavirus, and HPV is linked with ultimate possible cervical cancer. So that's why there's the risk of cervical cancer. There is a decreased risk of endometrial cancer and ovarian cancer. So overall, there is a decreased risk of cancer if patients continue to use barrier methods for STD protection. The hormonal contraceptives are contraindicated in cardiovascular and thromboembolic disease, estrogen-dependent neoplasms or cancers, liver disease, and pregnancy. Also, obviously, pregnancy. Also, avoid use and use barrier methods in drugs that induce CYP3A4 and with antibiotics. Drugs that induce CYP3A4, like a major one here is rifampin. Rifampin is a really strong CYP3A4 inducer, and the reason for this is the hormones are metabolized by CYP3A4. So if you induce the enzyme, they're going to be metabolized much quicker and they will not be effective and you'll have contraceptive failure. There's also a issue with hormonal contraceptives and antibiotics. This is a really common one to look out for. When you have a young female patient who is getting antibiotics, it's incredibly important to ask them if they're on hormonal contraceptives because there can be an interaction there. Antibiotics can alter the GI flora, which we know this, they kill bacteria, so they can alter the GI flora, and they can reduce the enterohepatic cycling of estrogen. So because of that, we won't, typically estrogen, it'll go into, it gets filled out and then pulled back into the system again, but it blocks that so that it just, it will, get pulled out and we never reabsorb it again. So it just leaves in the feces instead. So while patients are taking antibiotics, they need to use barrier methods. So use a condom. And the recommendation here is to use barrier methods while on antibiotics. You should use barrier methods for the rest of that cycle. Because once you interfere with the hormones in that cycle, you need to be careful for the rest of the cycle because you can't guarantee that an egg hasn't been released, for example, during that period of time. And then just because you take estrogen the next day doesn't mean that egg's not going to be, the egg's already released, it's already there. So use barrier methods for that cycle. So if somebody takes an antibiotic during the second week of a 4-week cycle, they need to use barrier methods for the rest of that 4-week cycle. So combination oral contraceptives, again, contain both estrogen and progestin. The estrogen is typically ethinyl estradiol. The progestin can vary based on the specific brand name that you're using. Norethindrone, levonorgestrel, desogestrel, norgestimate, drospirenone are all possible progestins that could be that could be present in the contraceptive. There are also multiple different dosing variations or ways that the hormones can be dosed throughout that cycle. Monophasic, mono is just meaning one, so think like one phase. Monophasic contraceptives give you a constant dose of both hormones, and you get that constant dose of hormones over 21 to 24 days. Again, remember contraceptives are based off of a typical 4-week cycle or 28-day cycle. So typically the first 3 weeks are dosed with hormones, and then the last week is the placebo week. So most will have 21 days of hormones and then 7 days off. There are some that have longer hormone days or longer, to 24 days of hormones. But monophasic have that one phase where you have a constant dose of hormones over that whole period of time. Triphasic have a constant level of estrogen, but tri means 3, so there are 3 phases of the progestin. So the progestin increases over the 21 days. So like each week, the first week you have low progestin, then the next week you've got more progestin, then the next week you have the most progestin. This tries to mimic what happens naturally the most, because in your body, hormone levels change as you go through the cycle. So that's what the triphasic is trying to mimic. Again, they're based off of a typical 28-day cycle. The active pills, active just means that there are hormones there. There are hormones present in the pill. The active pills are typically taken for the first 21 to 24 days. And then placebo is taken for 4 to 7 days. Again, withdrawal bleeding. Withdrawal bleeding or menstruation occurs during that placebo week when hormone levels drop because the pills don't contain any hormones in them. Now, there are extended cycle forms of combination contraceptives. So extended cycle, instead of having a 28-day cycle, it has a longer period. It's like essentially a 3-month cycle. So 3-month long cycle. Extended cycle pills have active pills for 84 days. So that means there's hormones that are taken steady for 84 days and then placebo for 7 days. So patients who are on extended cycle pills would only have would only menstruate or would only bleed once every 3 months, which is pretty convenient. There's also continuous contraception. And this involves taking active pills daily. So there's no placebo, which means there's no menstruation, so no bleeding. Now, extended cycle and continuous contraception, patients are more likely to have breakthrough bleeding or spotting. So not necessarily a whole period, but patients are more likely to just kind of have a little bit of bleeding occur every now and then. Which is not as predictable, but it's just very, very light, very little bleeding as opposed to a typical menstrual cycle. And this is okay. Like there's nothing that says you have to go through the menstrual cycle each month. Like the uterus is okay if it does not shed its lining once a month. There's also, instead of taking the pills, the hormone pills, there's also transdermal hormones or the transdermal patch, where the hormones are given via patch. They just cross through the skin and get absorbed that way. Efficacy of the patch is comparable to oral tablets, except in women that are more obese or larger women. So less effective in women who are over 90 kilograms. This is likely because the hormone probably accumulates in the adipose tissue, the fat tissue. These hormones are lipid-based hormones. So it is possible that if there's a lot of lipid tissue present, that the hormone will just accumulate in the lipid tissue, which means less of it's going to actually get absorbed into the bloodstream and be able to go work. So in patients who are over 90 kilograms, we do see that the patch would not be recommended. The way that the patch is applied is you apply one patch weekly for 3 weeks and then take 1 week off with no patch. So the patch does have to be changed once a week. It's nice to, if the patient applies it on a day that's kind of different, so maybe on Sundays. It's harder to remember on a weekday because they're all kind of the same, but they need to pick one day a week where, they'll be able to remember it, time of day that they can remember, where, every Sunday morning an alarm goes off at 9 a.m. That's when they take the patch off and put on a new patch. And then again, the 1 week where there's no patch applied is the week that they would bleed, that menstruation would occur. The patch should be applied to the abdomen, which you can see in the picture here. This is the patch being applied to the belly. The upper torso, which upper torso meaning like the deltoid or scapula area, so this kind of region, or the buttocks. And it's okay, like, to shower with it or go swimming with it. Like, there's not any restrictions as far as what the patient can do while the patch is applied. Total estrogen exposure with the patch may be considerably higher than with oral tablets. So if you have a patient where you're concerned about estrogen exposure, do not use the patch in them. If you're on the line, like thinking, okay, is a combination okay, or should I do progestin only? And you decide the combination is okay, I would give oral, not the patch, because estrogen exposure can be quite a bit higher with the patch. And that's probably because there's so much variation in absorption with the patch that in order to ensure that they get enough absorption, there has to be an excess of drug. So if the patient happens to have really great transdermal absorption, they can end up getting more of the drug than the average typical person. There's also a vaginal ring. It's a little flexible ring that you can see right here in the picture, and the ring gets pinched just like you see, and then it's inserted up in the vagina. It goes into the back of the vagina and just kind of curves around the cervix. So if you look in the picture right here, you can see the uterus, right? And then the cervix of the uterus is the little C shape right there, right at the back of the vagina. And the ring gets inserted up into the vagina and just kind of curls in this little cavity right here around the cervix. So it stays because the way that it's horizontally placed like this around the cervix, it's not going to fall out because the inferior or kind of distal portion of the vagina is more vertically kind of oriented. The vaginal ring contains a combination of ethinyl estradiol and etonogestrel. Efficacy, again, is comparable to oral formulation. The ring is inserted into the vagina for 3 weeks, then it's removed for 1 week, and during that 1 week, menstruation occurs. Progestin only pills, again, are available for patients who should not have estradiol, or for who it's not safe to have estrogen exposure. They only have progestin, so that norethindrone is typically what we see. This is frequently called the mini pill. Now, this is taken daily to provide a continuous low dose of progestin, and it is less effective than the combination. So we do see a higher failure rate with progestin-only pills. Otherwise, it's like, why not just give everybody progestin? Why give the combination? The combination is more effective. The progestin-only pill is less effective at preventing pregnancy, and we do see more irregular menstruation, meaning like less predictable menstruation. Your menstruation might occur a little bit early, it might occur a little bit late, it might be really heavy one month, like a lot of blood loss one month and not very much the next. There's a lot more irregularity when progestin-only pills are used compared to the combination. However, remember, there are some situations where estrogen is not safe to give to patients. So in those situations when estrogen cannot be used, we can give the progestin-only pills. So some examples, in patients who are breastfeeding, remember we said that estrogen can interfere with lactation. Now, I've heard multiple people say that you can't get pregnant while breastfeeding, which is not true. It's simply not true. You can get pregnant while breastfeeding. Ask any mom who has 2 kids that are really close together in age. You can get pregnant while breastfeeding. So if you have a patient who is breastfeeding who wants to start taking contraceptives, you can give them the progestin-only pill, and that's going to be a lot more effective than nothing. Also, in older patients, who are smokers or have some sort of a cardiovascular or clot risk that makes you turn away from estrogen, then we can use just the mini pill in them. There's also an injectable progestin, specifically medroxyprogesterone, that can be used. It's convenient because it's just an injection every 3 months, but there are some kind of other downsides. So it provides a high continuous dose of progestin across that 3-month time. It's injected either subcutaneously or intramuscularly just once every few months. Adverse drug effects include amenorrhea and weight gain, but other kind of possible issues with the medroxyprogesterone are, one, that there's a delayed return to fertility after it's stopped. So it can take several months to return to fertility. So if a patient, just wants to, say they just got married and they're like, well, we want to wait at least 6 months before we have a baby, this probably is not the best idea for them to go on, because they're going to want to get pregnant sometime in the near future. But otherwise, if the patient's okay with, waiting a long time to get pregnant afterwards, or doesn't want to get pregnant at all, then this is okay. However, there is a total limit of 2 years of use, so patients cannot use this for more than 2 years due to bone loss. Medroxyprogesterone causes bone loss, and it can predispose a patient to osteoporosis and fractures. So we typically limit the use unless the patient just can't tolerate anything else. If there's just no way for them to tolerate anything else, then you can use it longer, just monitor bone density, but in general we try and limit to 2 years. There's also progestin implants. So progestin implants can be done either in the upper arm, or there's also progestin intrauterine devices. Progestin implants and intrauterine devices are what we call long-acting reversible contraceptives. So long-acting reversible contraceptives, or LARCs. The other long-acting contraceptives are not reversible, like tubal ligation, so female sterilization or male sterilization. That's not reversible. But these are long-acting reversible contraceptives. They're implanted, so it's a simple procedure, but it's still a procedure to implant them. So it's not something that you can just take off on your own or just stop using on your own. They're intended to be used for long periods of time. Again, the esterogestrel implant is implanted subdermally, so just underneath the skin in the subcutaneous area in the upper arm, and it's implanted for a 3-year period. So every 3 years, if you want to continue to use it, you have to go and have the procedure to have it removed and have a new one put in. It has efficacy equal to sterilization. So it is extremely efficacious. It works very well, and it is reversible upon removal. So if you have a patient who is just positive 100%, they do not want pregnancy for at least the next few years, and they don't want to, you have to remember, take something every day. This is relatively simple. When you have to consider the long term, it's simple. You don't have to remember anything. It's just annoying for that first period of time. Adverse drug effects, however, include irregular bleeding. Again, anytime you have something that's not mimicking the normal cycle meaning 3 weeks of hormones, 1 week of bleed, 3 weeks of hormones, 1 week of bleed. Anytime you try and stretch that out longer and have just steady hormones constantly, there's more of a chance of irregular bleeding. And then headache. One thing to keep in mind, this has not been studied in patients who are over 130% of their ideal body weight. So caution, right? It may not be as effective in patients over 130% of ideal body weight. That's kind of similar to what we saw with the patch, right? The patch had decreased efficacy in patients who were over, I think it was 90 kilograms. Progestin intrauterine device. This is another form of long-acting reversible contraceptive. This is levonorgestrel. The efficacy, again, is similar to sterilization, and again, it's reversible upon removing, so it's another good thing for long-term use. It works for 3 to 5 years and is suitable for women wanting a long-term contraception. This is highly effective for women with heavy bleeding. Some women have really tough menstruation with heavy bleeding and a lot of cramping associated with it. And this happens to be really effective in this subset of patients at reducing that or getting rid of that, which if you imagine a week every month where you're plagued by really bad cramps and really heavy bleeding, and you're always worried about blood getting on your clothing, and it interferes with life. So this can be really effective for that subset of patients. Caution though, avoid in patients with pelvic inflammatory disease and a history of ectopic pregnancy. Note, this is an actual hormonal intrauterine device. There is a non-hormonal intrauterine device. It's copper. There's a copper intrauterine device. This provides contraception for up to 10 years. And again, it is non-hormonal, so you take away the concerns that you have with hormones. Postcoital contraception is contraception that is taken after sex, typically unprotected sex or sex where contraception has failed. And this reduces the probability of pregnancy after intercourse without contraception. Postcoital contraception is recommended regardless of the time and cycle. So what we mean by that is, you can look at the place in a cycle that a woman is and predict whether or not ovulation is occurring, within a few days of that intercourse. If ovulation isn't going to occur within a few days of intercourse, then it's not likely that the woman is going to get pregnant. However, if a woman has unprotected sex and does not want to get pregnant, we do not worry about predicting if they're ovulating or not ovulating, because it's not a perfect science. Regardless of where they are in their cycle, they could be scheduled to start their period in 2 days. Doesn't matter. Regardless of where they are in their cycle, if a woman has had unprotected sex and does not want to get pregnant, we recommend postcoital contraception. Also, something that's really important to keep in mind for you to be ready to educate patients on is that these are not abortificants. Like, these do not cause abortion. They do not cause abortion. They prevent ovulation from occurring. So they prevent the egg from being released so that it can't get fertilized. If an egg gets fertilized, these are not going to do anything about it. Like, it's there. They don't interfere with implantation. So if an egg is fertilized, these are not going to stop it from getting implanted. They do not stimulate uterine contractions. So if an egg is implanted, they're not going to cause it to be expelled from the uterus. They do not cause abortion. They simply do what all other contraceptives do. They prevent the egg from being released. That's it. A lot of people have these misconceptions that these cause abortions. They don't. It is completely different. So there's a single dose or single high dose of levonorgestrel. This should be taken within 72 hours of unprotected sex. So that's the goal, to take it within 3 days of unprotected sex. The sooner you take it, the better. So you should counsel patients. If a patient is getting this and it's only been 24 hours, don't let them think, okay, well, I can wait anytime in the next 2 days is fine. No, take it then. Like, it needs to be taken immediately. The sooner it's taken, the better. Because for all the patient knows, they might ovulate while that's still getting absorbed from the stomach. So they want to take it ASAP. Now, efficacy with levonorgestrel, efficacy has been shown up to about 120 hours. So the greatest efficacy is within the first 3 days. However, if it's been 4 days, I would tell somebody, go ahead and still take it. If it's been 5 days, I would tell somebody, hey, go ahead and still take it. Okay, efficacy has been shown up to 5 days, but we recommend within the first 3 days because that's when the highest efficacy. Ulipristal is indicated for emergency contraception within the first 5 days after intercourse. So that just has a little bit longer of a recommended date. Ulipristal is a selective progestin modulator, also prevents ovulation. Something to keep in mind is that these are not perfect. They have really good efficacy. They're better than nothing. They do really well, but they're not perfect. So even if these are given, you still need to check for pregnancy. The next month, the patient still needs to be checked for pregnancy just in case. Copper IUDs are also effective as emergency contraception within 5 days of intercourse. So this is it's an intrauterine device, so it's harder to get. The other agents, you can just go take the pill, that's it, it's easy. Or take a couple pills and it's easy. This is harder because you have to have a procedure. You have to have the intrauterine device implanted. However, it then remains long-term. So that might be a good choice if you have somebody who knows that they don't want to get pregnant. They just have never, really taken anything before, or they don't want hormones or whatever. You can implant the intrauterine device. It can work as emergency contraception, and then they're also good for the next 10 years as long as they have it. Also, something else to keep in mind is that copper works regardless of weight. The other agents become less effective as weight increases. So once you get to 130% of ideal body weight, the higher up in weight that the patient goes, the less effective the other agents are. So copper is a good choice in a patient who was obese. Again, it's an intrauterine device, so it requires a procedure, but it is highly effective. And that is it. Thanks, guys. If you have any questions, shoot me an email.